Okay, so last time we were talking about ways that makes these microbes to be antibiotic resistant. And then classical is using outdated or weakened antibiotics, using someone else's prescription, or not finishing the actual prescription time. And then as well, there is, it's an effort still, but there was a ban about using antibiotics in animal fed, but they still use them. Cattle, poultry, they use it to keep the animals healthy. But that actually poses a risk for us because many of these animals, when they get in contact with bacteria, these bacteria will become antibiotic resistant. And then when we poorly cook these products from these animals, then and we consume it, then we can get these bacteria in our body. And then something that can be done to prevent this from happening, it will be, of course, in that case, to stop using this type of practices. And then, of course, finish your prescription. And if you have leftovers antibiotics, or if you left your antibiotics in an area where you shouldn't have left them, like direct exposure to the sunlight or in the car, just don't use them. And then there is places where you can go and throw them away so that they can be safely disposed. And then something that is happening as well as part of this resistance to antibiotics is that developing new antibiotics is costly. It's getting every time more costly to do the research, do the trials, and then, pharmaceutical companies don't think like they are very generous, so they want to have their return of investment. That basically it's to the cost of the public. And then in terms of healthcare workers, well, avoid unnecessary prescriptions and then choose the appropriate antibiotic for the appropriate target. It is sad, again, and I have seen it, that people, they don't get happy if they don't go out with a prescription, without a prescription. So, and they just say, you're not a good doctor. And, well, anyway, so now let's look at antibiotic safety. And it applies to many drugs, the safetiness. So we have something that is called therapeutic index, that whenever they do the research, they tell you, well, this number of milligrams has been shown to be safe for the patient per kilogram. And then they give you more or less a chart or table that you're supposed to use, because if you don't use it appropriately, it depends on the antibiotics, you can cause damage, organ damage, like you can cause kidney damage, damage the ears, damage the bone marrow, etc. So that's one factor, knowing the therapeutic index, and then knowing the risk versus the benefit. Unfortunately, many times you can try to follow the therapeutic index. However, the patient itself, it will have certain conditions that it will prevent you from using that particular drug. Or maybe you might want to use it if it's appropriate, and then run the risk versus the benefit. An example that typically happens is in the elderly. In the elderly, you don't have to use the same dose of antibiotics or any other drug as a normal adult, because the body systems have declining function, and then you can damage more than what you can help. You also have to take into account if the person is taking any other drugs that can potentially increase the risks, or they might have an adverse reaction when they are taken together. So things to keep in mind. And if the female, in this case it's a patient, the female is pregnant, then definitely you have to think about what is the potential effect in the baby. Okay, so those are things to keep in mind. Now let's look at a case of synergism and compared to antagonism. So many drugs work better together than alone, and then some of them they can compete. So synergism is when the effect of the drugs is higher than when these ones work alone. Antagonism is when two drugs work less effectively than when they're working alone. So here we have this close-up of the top of a Petri plate with this antibiotic disc to test the efficacy against a particular bacteria. It can be a case of maybe a gram-positive. So here we have ceftriaxone, 30 milligrams, ampicillin 10 milligrams, astronam 30 milligrams, and then amoxicillin with clavulanic acid. So amoxicillin with clavulanic acid, it's a combination that typically it's available commercially because they know that this amoxicillin, it is more effective with this clavulanic acid. In this case, clavulanic acid prevents the damage of the drug caused by penicillinases. So this is an anti-penicillinase, so it works against this enzyme that can break down amoxicillin. And then you have good halo of inhibition around this disc. So that's the normal activity of this drug. Now, in this case, again, let's say that it's a gram-positive, ampicillin, which is similar to amoxicillin, it's a beta-lactam, in this case is not effective against this microorganism. And maybe previously it was. So then in this case, this drug is pretty good, and ceftriaxone doesn't have good effect, just as ampicillin. Astronam, more or less. I mean, you see like kind of a very small halo, but then look at the synergy that happens when you have astronam and then you have nearby amoxicillin and ceftriaxone. So they just label this part where you have extended inhibition of growth, and this one they didn't label. But then look at ampicillin with amoxicillin. Well, there is no synergism. But with the other two drugs, there is. Now, I don't know how will it happen, but I don't think it will happen. No one will use this drug alone plus this. I don't want to criticize if someone does it, but if someone does it, I'm pretty sure that it doesn't know what it's doing. So, and I cannot call it worse than that, but you know what I mean. So, I mean, why would you spend money giving ampicillin and amoxicillin with clavulanic acid that by itself is good? And this one actually doesn't need to have a combination with ceftriaxone or astronam, but just in case, I mean, this one, it tells you then that there are certain drugs that can work together and others they won't. Interesting enough will be to see if amoxicillin itself will work together with astronam, causing the same synergy. Basically, what I'm saying is if we remove clavulanic acid, what will happen? And then same for this. Will it still be the same or not? Now, chances are, by itself, guys, that this microorganism, it is actually resistant. So it is one of these ones that it is having penicillinase. So that's why ampicillin doesn't work if it's a gram-positive. And now for tetracycline. Tetracycline sometimes interferes with the activity of penicillin. Do you imagine why this happens? This is one question, like why tetracycline can sometimes interfere with the activity of penicillin, and how?
Something to do with its chemical structure and sort of, I guess, maybe bonding to penicillin in some way, and sort of maybe breaking a bit of penicillin.
And it says sometimes, not always, right? So what is the mode of action of tetracycline, if you remember?
It blocks the RNA from coming into the codon for trans.
Yeah, it blocks translation in essence, right? And penicillin, it inhibits the formation of this peptidoglycan. But then why these two, if they have different mode of action, why will they maybe sometimes interfere rather than be synergistic?
Well, since tetracycline blocks protein synthesis, maybe it blocks the synthesis of the cell wall a little bit. So then penicillin wouldn't.
It can be, no, it's not crazy. Another thing, what about the channels that makes penicillin to go inside into the cytoplasm? In this case, if there is no channel, then penicillin cannot go in. So I guess it will depend on how would you use them, if one before the other one. So you can weaken the bacteria and then at some point make it strong in a way. And now let's look at 3 areas of research of new antimicrobial agents. So, well, this problem is being chronic. I mean, in terms of research, they start to see a lot of antibiotic resistance early in the 60s. So, I mean, unfortunately, back then there weren't that many tools that we have nowadays. And then, unfortunately, many of the research that has been done has been focused into why this happens, but they haven't come up with many alternatives of antibiotics. But we now have been trying to find perhaps targeting virulence factors of a specific bacteria. So that way, when you give an antibiotic, you will affect only that kind of bacteria, not the normal flora, which in many cases is necessary to prevent the action of pathogens or the binding of pathogens into our receptors. And then we have some microbes that they live at the expense of iron from the host. So they have actually specific proteins that can sequester iron. And then we have also in our body proteins that steal the iron back from the microbes. But they wanted to find kind of the same, or they wanted to have an antibiotic that works based on that, just like as they did with interferons for treating during viral infections. And then they're trying to find, other than tetracycline, for instance, that it's working against some of these intracellular parasites or pathogens, seek drugs that combat dormant, persistent cells. That, I guess, will include preventing chronicity from hepatitis B or C infections, and also from herpes virus or HIV. And then typically gram-positives are really easy to treat. However, gram-negatives not. And then you know the reason. We have this periplasmic space filled with a bunch of enzymes that can degrade these antibiotics and also the disinfectants. So then there is some effort to target more gram-negatives. And in itself, gram-negatives, it gives more symptoms than an infection with gram-positives. Because when this bacteria is dying, it releases the LPS that leads to high fever, vomiting, nausea. And then they're trying also to find ways to test antibiotic susceptibility for microorganisms that cannot be cultured, like, for instance, chlamydia, rickettsia, etc. And then a good new development is happening with antimicrobial peptides. So it is well known that many microorganisms produces these peptides as a mode of antagonism naturally. So they're trying to find new sources for using this type of antimicrobial peptides. So testing them and see if they are efficacious. Same for bacteriocins, which is one of these antimicrobial peptides, and the use of phage therapy as part of the immunotherapy, because phages can actually target these bacteria and bring some of these drugs with them. So here we have an example of this type of research that they're doing. So they can grow in a closed strict pattern, as you can see very clearly from this picture plate, methicillin-resistant Staph aureus. And this in the center, or well, it has, they grew in them lactobacillus. So lactobacillus, if you remember, has an acidic, it's an acidophile. It releases acids, that's why it's used to make yogurt. So with the release of this acid, it is preventing the growth of these Staph aureus. And then we know that the acidity has been decreased because this media, it is based on a pH 7, and then the center of the well, it is having acidity that it is produced by this lactobacillus. So this is an example of antagonism, and then maybe to start using it for treatment. So that's all for this chapter. Any questions?